Okay, let's get started with the next session. Our apologies for some technical issues with the slides. My name is Toby Gerhardt. I'm at Rutgers University, and I will moderate the session. Given that we already lost a bit of time because of some technical difficulties, I'll keep the introduction brief. We have a really fantastic and impressive panel of 4 speakers coming up that will all address methodological issues of addressing comparative effectiveness in diverse population. The first speaker is Dr. Michael Theis. He's a professor of psychiatry at the Perelman School of Medicine at the University of Pennsylvania. He has published widely on the assessment and treatment of mood disorders and will speak on comparative effectiveness of treatments for depression, research strategies to compare the almost incomparable.
Thank you. I want to begin with an apology for missing the deadline. My slides are not in your book. There's nothing proprietary about them. I missed the deadline. My mom passed away a few weeks ago. I'm behind in everything, and bear with me, and we'll figure out a way that I can send them to those of you who would like the slides today. I want to begin with a disclosure that I do a lot of work with the pharmaceutical industry. I continue to believe that they represent, the U.S. pharmaceutical industry represents our best hope for the development and rapid introduction of effective new treatments for our patients. I understand not everyone believes this to be true. We disagree. I respect your alternate view. So this is a really important topic, the comparative effectiveness of treatment of depression. Depression is one of the world's great public health problems. There has been an epidemic of sorts over the last 4 birth cohorts. It is considered by the World Bank and the WHO to be the 4th greatest public health problem and to be the number 2 public health problem by 2020. It costs the U.S. economy almost $80 billion a year. The vast majority of those costs have nothing to do with treatment. They have to do with the cost of the illness. It is the leading cause of absenteeism and presenteeism in the U.S. workplace, and it's the leading cause of suicide, which, depending across all of our adult age groups, is the 12th leading cause of death. And I will say flatly that comparative effectiveness is a topic that is not being adequately addressed by the current alliance of the NIMH industry and academia. If I could morph into Princess Leia and look through hologram to Obi-Wan Kenobi, I would say, AHRQ, you are our only hope to do better, meaningful work on public relevant research for depressed patients. Here's a really sad story. You'll notice that there's not been a major treatment development for depression in a long time. If you think about it in an alternate view, that's a great time to take stock about the comparative merits of our different treatments. And we have efficacy research issues to tackle in order to do a better job finding new treatments, but there is no answer directly in sight for that. So in the meantime, this is a perfect time to take stock in what we do have. I should also disclose I'm a randomist. I believe in randomized studies. That's my mother's milk, a bad pun, but it is something I believe very strongly in, but see a really wide range of studies that can make use of randomization. So obviously for random assignment, you remove as many biases as you can, and you can address the few that survive random assignment. The other core features of an RCT, of course, include following a protocol, the better specified, the more reproducible, the use of blinded evaluation, and the essential requirement of either a placebo if the treatment is unproven or of uncertain value, or a standard active comparator in the cases in which the treatment has certain value. And those are the kind of questions we'll be talking more about today. But as I said, we have real problems in efficacy research. You might have heard in the newspaper in the past year that antidepressants don't work. At the base of this is the fact that placebo response rates have doubled in the last 20 years. This is not because placebo is twice as effective as it used to be. The designs in the patients are resulting in placebo response rates twice as high. Unfortunately, since about 25 to 30% of patients drop out of these studies, when the average placebo response grows to 45%, you have a very narrow and progressively shrinking window for assay sensitivity. And this is the fundamental reason why modern antidepressants look weaker than older antidepressants. There are massive cohort effects within all of our data sets. Placebo is growing in effectiveness, antidepressants are not. The window is narrowing. Now, all of that said in sort of a ranting way, these properly controlled studies are perfectly good to demonstrate efficacy and get a drug to market or to bring a new psychotherapy to a wider range of dissemination, but they tell us essentially nothing about the ultimate utility of those treatments for reasons you all know well. In my line of work, 90% of patients with the disorder of interest are excluded from these trials, and there has historically not been anything to take over the next level of treatment after phase 3, or there's not been much of anything to take over the next level of treatment after phase 3 in the post-approval world. So the comparative effectiveness of most of these widely used treatments, at any point in time between 15 and 20%, the adult population of the U.S. takes an antidepressant, and there is not adequate comparative effectiveness research for these interventions. And so we're going to just move away from efficacy research. It won't answer our problems. I'll just ask you, if you were depressed, knowing what you know, would you consent to a double-blind, placebo-controlled study? And typically less than 5% in a room without a rushed behind speaker will raise their hand and say, yes, I would. And I honestly wonder if that 5% really would. These studies are not representative of the patients that doctors and other therapists treat on a day-to-day basis. Yet time and again in the 90s and in the first decade of the 21st century, when we tried to pull non-research settings into doing research, enrollment rates were terrible, and when we succeeded, by the end of the study, they started to look more like research settings. So the better the non-research setting becomes at looking at research, the more it morphs into a more research-like setting. So there are some grave challenges. So I think the major design considerations here are large, relatively simple studies, ideally two-group, comparing the existing standard for that level of consideration versus the most promising novel intervention. And an elaboration of this design is a two-strategy comparison. And so you might pick pharmacotherapy with antidepressants versus psychotherapy with several members of the classes in there. Depending on the question, this could either be a superiority trial. The good news there is you'd only have to enroll 600 patients to do a properly powered two-arm study, or a non-inferiority design in which you might have to enroll as many as 1,800 patients. And there is not a controlled study in psychiatry that involves 1,800 randomized patients. You move down through, it is possible to address questions with non-randomized data sets using propensity analyses and so forth, but at the end of the day, that's probably more of a confirmatory data strategy than an actual comparison. You can never control the fact that the treatment wasn't randomly assigned, that doctors who give patients ECT and patients who accept ECT are not the same as the patients who are on 3 drug combinations from doctors who don't use ECT. So we need networks that involve real patients seeking real treatments in real clinical settings. These real settings should be collaborators and full participants in the process, and to follow the comparative effectiveness design, use relatively simple, valid, patient-reported outcomes. The Beck Depression Inventory, a perfectly good one if you don't mind paying the fee. The self-report version of the QUID being a better one because no fee is involved. I'll just reiterate that you need large samples to study large but relevant effects, and you typically cannot see an effect larger in one of these kinds of not so highly controlled trials than you can see in the contemporary placebo-controlled trials of the same disorder. And so we're clicking in at an average 15% drug-placebo difference in contemporary research. So that means the study does need to be powered to find a 10% difference or less in the modern era. So let me just start at the top. We have a really wide range. Depression is a very heterogeneous condition, and it goes from folks sitting in this room who are still working or who are back at your offices still working for you, the walking wounded, if you will, to people who are hallucinated and disabled and barely able to bathe and need assistance with activities of daily living. There is obviously no relevant treatment comparison that would engage that full range of patients. So what I'm going to suggest, akin to a propensity comparison, is you ask questions that are relevant to different segments of the population with different treatment needs. Within that, Americans have an amazing range of preferences and acceptabilities. As you know, Americans would rather go shopping than take a depression treatment. And within the depression treatments, they would rather see a psychotherapist than take a medication. Yet at any given time, among those treated, 65% are taking a medicine and 35% are seeing a psychotherapist. So the what people say they want and what people do are widely different. And unfortunately, these preferences and acceptabilities vary, and they're co-founded with relevant, important dimensions of the illness. People who go see a primary care provider aren't looking for psychotherapy. People who go see a psychotherapist often don't wish to take antidepressant medication. People who see psychiatrists are willing to take more invasive treatment strategies than people who see non-psychiatrists. And there are relevant sociodemographic variables as past treatment history as well. So I wanted to end my brief time with a parable about two relatively contemporary studies that tried to use state-of-the-art methodology in 1999, 2000 to address important public health questions using a novel method, equipoise stratified randomization. These studies are called STAR-D and STEP-BD. They both lived from 1999 to 2006. They rest in peace. STAR-D was about treatment-resistant depression, and I'll tell you just a bit about it in a moment. STEP-BD was about bipolar affective disorder, but primarily about the depressed phase of bipolar affective disorder. And there are four common suspects with these studies. Phil Lavori, who was the senior study statistician, Steve Wisniewski, who was the second statistician and who ran the data management center for the study and will co-author the paper that comes from this talk, and myself. Those are the three living suspects. And then the fourth is this equipoise stratified randomization. Now, what is it? It assumes that within a reasonable array of treatments, that patients do have differing histories of exposure and different preferences, and that as long as you can retain one randomized two-group comparison from that array, that you can engage that patient in the study. And so, for example, this might permit you to compare four different strategies with different levels of acceptability as long as the smallest pair of acceptability still had adequate power to meet the aims of the study. And here's a simple example with a three-group comparison, and that would leave you with four real strata, the people who would accept any of the three or any two of the three. And you can see how the pairwise comparisons would be constructed, and that you would need to know in advance which is likely to be the rarest of the comparison of the acceptabilities, because you would need progressively to oversample to fill that strata. It is advantageous because it is generalizable, and you can construct valuable two-group comparisons with certainty within it. But it is complicated, and unless you know in advance what the acceptabilities are and monitor or pilot test and or monitor throughout, this can backfire. And I'll show you a sobering parable of that in a second. STAR*D, as I mentioned, was a study about treatment-resistant depression. It contained 3 randomized trials within it. 2 of the 3 trials involved comparisons of switching versus combining or using adjuncts. And STAR*D was inclusive. You basically had to have depression, not be about to die, and not have a medical condition so worrisome that you might not die in the next year, and depression needed to be the principal treatment condition. You could have many comorbidities and be in the study. So to show you just how generalizable it was, only 20% of the STAR*D sample would have qualified for a modern randomized controlled trial, so it included much more complex and highly comorbid patients. And then here's where things began to go wrong with STAR*D. The magnitude of the dropout was underestimated and grew progressively over the sequential pace of the study. That's what we came to call treatment fatigue. And treatments that we had as individual investigators gotten patients to accept random assignment to in many 2-group and 3-group studies, people suddenly had strong preferences and boxed out of the equipoise stratified random assignment. The patients who were randomized controlled trial eligible had better outcomes than the patients who weren't. So nested within the criteria used to qualify patients for random assignment appears to be good prognostic indicators, which also points to why the placebo response is high. 7 groups compared at the first randomized level. Kids, don't do this at home, and never do. I will never do this again. Anything more than 3 is asking for trouble. Our patients, 5% accepted any of the 7, so we had no across 7 comparisons. Shockingly, only 20% were willing to accept a switch versus an augment. Even though doctors do this every darn day in practice, only 20% of the patients were willing to accept this in this model. And only 30% of the patients accepted psychotherapy, even though it's a precious, highly desired resource, and even though we always do well enrolling patients in psychotherapy studies. So we ran into profound problems. Now, here is where the equipoise randomization really hurt, because as you can see, it appears that adjunctive treatment strategies were superior to switching strategies at all levels of the trial. This trial was powered to detect 15% differences. They're there in the first 2 levels. But you cannot make these comparisons because the patients who accepted adjunctive strategies were less severely ill and had better tolerability of the medication. They had better prognostic indicators. So this could be an illusion, and there aren't enough randomized patients to sort that out. Psychotherapy held its own against pharmacotherapy, but with so few people accepting, we did not have power. And the word got out that, oh, patients don't like psychotherapy. That's just simply not true. The patients didn't enter psychotherapy in this study for complex reasons. I'm almost out of time. So why did so many people decline psychotherapy? The therapists were off-site. That's true in the real world. Insurance rules prevented us from making pharmacotherapy and psychotherapy equal cost. So the patients randomized to psychotherapy had to accept a greater out-of-pocket cost. Patients were allowed to come in with existing psychotherapy, but if they got randomized to the psychotherapy arm, they had to change. And it's possible people who wanted psychotherapy first never enrolled in the study because the study began with a medication trial. Step BD, the bipolar study, on the other hand, had 3-group random assignments, and the equipoise stratified randomization behaved like a racehorse. It permitted us to conduct meaningful studies of pharmacotherapy and psychotherapy concurrently, some patients opting out of the psychotherapy study, some patients opting out of the pharmacotherapy study, with a very robust, meaningful public health finding that patients with bipolar depression do not respond to modern antidepressants any better than they do to placebo, yet respond nicely to focused psychotherapies. So what did we learn in our experience? Conduct large studies in sites committed to conducting research. I would say audition sites. I think these large, meaningful trials actually need a year auditioning before the trial actually starts. Who can enroll, who can't enroll? I think people, altruism is a wonderful thing, but people don't really enroll in trials that involve randomization for altruistic reasons. It's like the number 6 reason on the list. Provide incentives that are not coercive, but meaningful for both the participant and the providers. Pilot test acceptability before ever using the ESR procedure again. And conduct trials within strata in which acceptability is reasonably comparable. So the depressive disorders are vital public health problems that we really do require further assistance from the research community to answer these important questions. And I think meaningful comparative effectiveness research in this area, as I'm sure in all areas, involves creative design, careful planning, collaboration across the stakeholders, funding agencies, academicians, consumers, providers, and anyone else I forgot to include in the slide that has a stake here. Thank you very much. Because my train is at 7 and we are late, I have permission to take one question now in case I have to bolt before questions. Come on, somebody has a question. Yeah? Okay, well, thank you so much for your kind attention.
So in the interest of time, we're moving on right away. The next speaker is Dr. John Kane. He is chair of the Department of Psychiatry at Zucker-Hillside Hospital, as well as professor and chair of the Department of Psychiatry at Hofstra North Shore School of Medicine. He currently directs the NIMH-funded Advanced Center for Intervention and Services Research in Schizophrenia at Zucker-Hillside. His distinctions are too numerous to elaborate in the interest of time, so without further ado, Dr. Kane, who will speak on the comparative effectiveness research in schizophrenia, the example of relapse prevention.
Thanks very much, and I want to thank Dr. Boa for switching time slots with me because I also have to make a plane. These are my disclosures. I want to emphasize that I've been a consultant to really all of the pharmaceutical companies that are involved in developing long-acting injectable antipsychotics. That will be a topic of mine in a few moments. I also have a financial interest in the company Metavante, which does live two-way video centralized ratings, and I will mention that as well in my remarks. I was not intending to talk about the RAISE project, but Phil Wong mentioned that before. The reason I wasn't intending is that this is still very much in progress, and we're not in a position to actually publish anything from this project, and I know that these lectures are intended to be part of a publication. The RAISE project is something that is a contract that was led by the National Institute of Mental Health. We are doing this in partnership with Bob Heinsohn and his team at NIMH, and the idea was to see whether or not we could change the trajectory of early phase schizophrenia. And by that we mean enhancing recovery rates and quality of life. Right now, if you look at first episode schizophrenia patients, the proportion who achieve recovery, which means working, going to school, being a homemaker, being able to indulge in socialization, to take care of one's day-to-day living activities, etc., is about 15% after 5 years. So these are first episode patients. So we have a long way to go in terms of improving recovery rates. And the intent of this project was to see if, via early intervention with a multimodal treatment program delivered by a well-trained and coordinated team of people, we could, in fact, improve the trajectory of this illness. It's a devastating illness. It affects thought, behavior, affect, et cetera, et cetera. So the intent was that this should be done in real-world clinics under the usual reimbursement constraints. So that was an enormous challenge. We have enrolled 35 clinics in 21 states across the United States. These are not academic centers. Some of them have had no experience doing research at all. We have trained their staff, and we are monitoring them to the extent possible for fidelity. We've developed a computerized decision support system for the physicians to help them use evidence-based medicine, measurement-based decision-making, et cetera. We have trained the psychosocial treatment team in psychoeducation, family therapy, individual resilience therapy, supportive employment, supportive education. We have randomized by clinic rather than by individual, and one of the challenges in doing a study like this in real-world settings is how do you do outcome assessments that are unbiased and blind. So that's where the centralized raters come in, using live two-way video from remote locations, raters who have no idea where the patient is, what treatment they've been assigned to, or anything else about them. That also enabled us to bring expert structured diagnostic assessments into these real-world clinics, no matter where in the United States they were located. So we've just finished entering 400 patients into this project. Each patient will be followed for at least 2 years, and we hope to have results probably in 3 or 4 years from now. Obviously, it's a tremendous privilege to be involved in a project like that. So I want to talk about the challenge that we have in preventing relapse and the issues that face us in terms of identifying the best methodology for comparative effectiveness in this context. These are data from a meta-analysis that we're currently working on, which compares the second-generation antipsychotics versus placebo in terms of the risk of relapse prevention. And we see that there's an NNT of 3. So the ability of these drugs to prevent psychotic relapse in patients with schizophrenia is very, very good. However, at the same time, adherence, which has come up in other discussions today, is a particular problem in people with a chronic and severe mental illness like schizophrenia, which affects judgment, insight, and cognition, along with the usual things that impede the ability of patients with chronic disease to take medication. If you compare adherence rates among patients taking antipsychotics with those taking antidepressants or those with a variety of medical conditions, we see that the adherence rates in schizophrenia are the lowest. So it would seem intuitively perhaps obvious that the use of guaranteed medication, long-acting injectable antipsychotic drugs, could be given every other week or every 4 weeks, would go a long way toward reducing rates of relapse. We have a class of medications that are highly efficacious. We have a population of patients that have a very difficult time taking oral medication on a regular basis. Therefore, it would seem logical that these formulations would be extremely helpful. These drugs were introduced well over 30 years ago. They have had their ups and downs in terms of utilization. Utilization rates in the United States have remained lower than in many other countries around the world. The slide in front of you now is a randomized controlled trial that was published in the New England Journal of Medicine that was sponsored by the Veterans Administration. Robert Rosenheck at Yale was the first author. This was double-blind, but that was also made possible by using centralized raters. So one of the challenges in comparing long-acting injections to oral medication is that it's very difficult to do blind assessments unless you do a double dummy, which means everyone getting injections and everyone getting oral medications, one of which is a placebo. And that in and of itself changes everything about the trial and the patient experience. So in this case, the raters were kept blind because they were remote using live two-way video to assess outcome. The primary outcome measure was hospitalization, and what we see on this slide is that there was no difference in terms of hospitalization rates between the long-acting injectable formulation and the oral formulation. One caveat is that the rates of rehospitalization in both groups were exceptionally high, 39% in the patients getting the depot and 45% in the patients getting the oral medication, higher than what you would generally expect to see. And that's partially due to the fact that this was a very, very high-risk population with a substantial prevalence of substance abuse, et cetera, et cetera. But the bottom line is this study failed to show the superiority of long-acting injectable drugs. We also completed a similar study with funding from the National Institute of Mental Health, an 8-site study which has not yet been published. We're in the process of writing up the data. Over 300 patients randomly assigned to long-acting drugs versus oral medication, again using centralized raters with live two-way video. No difference in terms of relapse or rehospitalization rates. We did see a difference favoring the depot drug in terms of overall psychopathology, but that would not necessarily be enough to drive payers or policymakers. So we have redone a meta-analysis that we published a couple of years ago comparing all of the studies involving random assignment between long-acting injectable drugs and oral medications, and now found that there is no difference in terms of relapse rates between these two modalities of treatment. Our previous meta-analysis had shown a significant advantage for the long-acting injectable drugs. We looked at a number of secondary outcomes, including all-cause discontinuation, discontinuation due to adverse effects, et cetera, and we did not find any advantage on any of these measures. There were 21 studies involving over 5,000 patients. The modal study lasted a year. Some lasted 2 years, none longer than 2 years. A variety of different medications were used. In some cases, the same drug was given in a parenteral form as in the oral form. In other cases, they were different drugs. As I said, none of the secondary outcomes showed statistically significant differences. So this is somewhat counterintuitive. How do we understand the lack of ability to show a difference in these randomized controlled trials? I should point out that there was one significant difference, and that is that the older studies, the studies that were done a few decades ago, were more likely to show superiority of the long-acting injectable drug over the oral drug. And there's another difference about those studies in that they all involve the so-called first-generation antipsychotic medications, drugs like haloperidol and fluphenazine. Some of us believe that the second-generation drugs do have advantages in terms of relapse rates. It's very controversial as to what advantages they have in general, but our meta-analyses, which I'll show you in a second, suggest that they are superior in terms of relapse rates. So we have a complicated picture in terms of a potential effect of time and potential effect of drug class in demonstrating these differences between delivery methods. This is the meta-analysis comparing second-generation antipsychotics versus first-generation antipsychotics in terms of their ability to prevent relapse, and we do see an advantage for the second-generation drugs. This has nothing to do now with depot, with long-acting injectable. These are oral studies. So what we've seen is that the so-called first-generation drugs, the older drugs, were able to show superiority of the injection over the oral medicine. We're not able to do that in all of the pooled studies or in the so-called modern-day studies. How else can we look at this? Well, cohort studies. So these are obviously patients who some physician, some nurse practitioner has decided that they should get a long-acting injectable drug, whereas other patients are getting oral medication. It's not random assignment. There are a variety of potential biases. We would expect, for example, that a physician choosing a long-acting injectable drug might be doing that because he or she has reason to believe that this patient is at high risk for non-adherence. Tehonen, using the Finnish Registry of Schizophrenia Patients, has published two very compelling data sets showing superiority for long-acting injectable drugs over oral medication, both cohorts involving several thousand patients. Significant advantages in terms of rates of rehospitalization. And if anything, as I said, there should be a conservative bias, right? Those patients getting the depot would probably be at higher risk for relapse based on clinical judgment. Another possibility in terms of methods to apply to this question would be mirror image studies, where each patient's history is used as his or her own control, and hospitalization experience is measured in equal periods of time before and after the initiation of the experimental or long-acting injectable treatment. The mirror image studies, we've done a meta-analysis of 15 such studies that we're able to find, and they demonstrate an NNT of 3, very powerful effect. But there are a lot of potential biases here. For example, in the United States, rates of rehospitalization have also been influenced by reimbursement considerations. It is much more difficult to get someone into a hospital than it was 20 or 30 years ago. Whether those changes occur over relatively short periods of time is difficult to say. The hospitalization rates in the cohort studies, I mentioned Tehonen studies as being highly significant in favor of long-acting injectable drugs. However, when we do a meta-analysis involving all 13 cohort studies that we're able to find in the literature, we do not see a statistically significant advantage for the long-acting injectable drug. So what is the most informative design to examine the impact of a long-acting injectable drug? Is it the randomized controlled trial, where we have selection bias? Patients have to sign a 20-page consent form. They have to agree to participate in either a double-dummy, a double-blind design, or some sort of randomization. There's usually very frequent assessment measures, reminders, adherence assessment, even for the patients taking the oral medication. Clearly a change in the ecology of treatment. In the mirror image studies, we have expectancy bias. We have the influence of independent factors such as bed reduction, et cetera, et cetera. And in the cohort studies, we have the potential selection bias, but that may be a conservative bias. So we're left with a challenge a major public health problem. I would argue that relapse is a very, very important public health problem. Schizophrenia is something that drives the economic costs associated with this illness, as does lost productivity, et cetera, but in terms of hospitalization costs, relapse is enormous. Yet we're having a difficult time getting a handle on something, on a question that is a very, very important one. So I think it's a challenge for us to try to grapple with this problem and come up with an answer in a way that would satisfy policymakers and payers who will have the sort of ultimate decision in terms of how widely utilized these drugs are. In my opinion, it's not the patient that is an obstacle to receiving a long-acting injectable drug. It's really the physician. Most patients will accept these drugs if you spend enough time discussing it with them and explaining the rationale. Many physicians are reluctant to do that, either because they don't believe it themselves, they don't have the systems in place to be able to provide injections, or it's just too much of a hassle. So I think this represents both a challenge and an opportunity for us to understand, how we can move forward in this area. Thanks very much. Take one or two questions.
We maybe have time. Can take one or two questions.
That was well done. I'm curious about the psychological barrier of the providers with monitoring. Independent of the injections, many of the white count monitoring and having the systems around that. Do you have any comment on the monitoring of the different agents?
So for the typical antipsychotic medication, there's relatively little monitoring. So only clozapine is associated with agranulocytosis. So we don't have to do frequent blood tests. There are monitoring requirements for the metabolic side effects of antipsychotic drugs, but I would argue that those are not terribly burdensome. The irony is that psychiatrists have a hard time even doing that, but there really is not a monitoring that should be an impediment in any way to the use of these drugs. These drugs are generally pretty safe. Right now we have a problem with metabolic side effects, weight gain, type 2 diabetes. It's obviously a larger public health problem in the U.S. in general, but it affects people with chronic and severe mental illness even worse. We have someone at the microphone.
Yes. Saying in this particular context you are changing it such that it can't be done anymore. That the benefit of the drug is that you don't have to be good at adherence. And a clinical trial, of course, it needs to be good at adherence by its very nature.
That is my hypothesis as well. But those of us who've grown up on the randomized controlled trial, and those payers who want to see more definitive evidence of an advantage, we have to figure out a way to, kind of work with them, convince them that this really is a cost-effective strategy.
Sorry, in the interest of time, we are unfortunately not able to take any more questions. The next speaker is Dr. Carlos Blanco. He's a professor of clinical psychiatry at Columbia University College of Physicians and Surgeons and at the New York Psychiatric Institute. He has done significant work on the prevalence and course as well as treatment of social anxiety disorders, as well of the treatment of commonly co-occurring diseases such as mood and anxiety disorders with substance abuse and other examples. And he will be speaking on clinical trials and comparative effectiveness on mental health.
I'll just move it with Thank you. So first I'm going to recognize the funding that I get from NIH. I get funding from NIDA, NIMH, and NCI. So I'm very grateful for that because that allows me to do the research. I also want to thank Naiwadwan, who is in the audience, who is a very important collaborator in all these studies and an inspiration for my work. So as Dr. Theis has mentioned before, of course, clinical trials have been traditionally the gold standard for establishing efficacy and effectiveness in studies. But, of course, as well, clinical trials are not without limitations, both in the implementation and also in the generalizability of results. So as a consequence of that, there's been, I think, a progressive movement in comparative effectiveness to use quasi-experimental designs. But quasi-experimental designs are also not without limitations. So what I thought I was going to do today was to talk a little bit about some of the usefulness of controlled trials as a tool for comparative effectiveness research in psychiatry, and then examine 3 examples of my own research, and maybe at the end have a little bit of a discussion on when clinical trials may be appropriate or useful and when other methods may be more appropriate. So one of the advantages of clinical trials, of course, is that the randomization and is the gold standard for efficacy and effectiveness and also for cost effectiveness. But one of the important limitations is that in general they have a limited statistical power to test the hypothesis. They also take many years to conduct. Often they took 4 or 5 years. Quasi-experimental designs are in general more generalizable to broader populations. They avoid the need for randomization, which can be difficult for certain conditions. And also they can provide an answer much more quickly. If we have a database that we can analyze, we can get an answer in a few months or a year. Other limitations of clinical trials is that there can be multiple testing. Also, the use of placebos, as Dr. Theis has mentioned, can be difficult to conduct a clinical trial. And also, they can be very expensive to conduct. At the same time, quasi-experimental designs can also be difficult to implement in the sense that I think it's very difficult often to find the right instrumental variable. Also, if we use propensity scores, we need to know the observable confounders, and if we have an observable confounders, then the estimate, if we miss those confounders, then the estimate could be biased. The advantages, of course, as I said, is that they have lower cost. So I'm going to talk about 3 potential problems that we have in psychiatry. They can generalize to other settings. And I'm not saying these are the most important clinical trials, but I'm just bringing them up because I work on this. I'm the PI of these 3 clinical trials, and I think they can serve as good examples for other problems. So one of the problems that we can have is that we may not have a standard treatment. So when we submitted this application, we wanted to compare one of the psychotherapies in cancer versus standard treatment. But it turns out the standard treatment for depression in cancer is no treatment. So the review committee wanted us to have a valid control. And as you can see in the slide, the prevalence of depression in women with breast cancer is very high. It's probably about 40%, 60% if you count symptoms. Depression worsens with the course of cancer. It worsens also compliance with cancer, and it worsens the outcome of cancer treatment. And so I think there's a need to conduct this kind of trials. Also, an important issue in conducting this trial in cancer patients is that, as Dr. Theis has also mentioned, although we have considerable information in the treatment of depression in the general population or in individuals who don't have any medical conditions, those individuals are individuals with medical conditions like diabetes, cancer, hypertension, are often excluded from clinical trials. So as a result, we have very limited information on how to treat individuals with medical comorbidities. So for those reasons, trials like this one can be important. So what we decided to do was to compare 3 different psychotherapies in women with breast cancer, and we are randomizing 150 patients. Right now we have already randomized 70. And we want to test is both the acceptability and the efficacy of these 3 psychotherapies. The 3 psychotherapies that we are using are one is interpersonal psychotherapy, and that's the mechanism of action of that psychotherapy is essentially that by improving interpersonal relationships and social support, the depression will get better. And there's a lot of information for the efficacy of IPT in the general population, and also from other studies that social support is very important in the improvement of depression. A second psychotherapy that we wanted to compare with a different mechanism of action is problem-solving therapy. And this is a type of CBT, of cognitive behavioral therapy, that what it tries to do is teach the individual effective coping strategies and also improve emotional control. And then the third psychotherapy that we are using, and I can talk more about that at the question and answer section if you want, is brief supportive psychotherapy. And the goal of that psychotherapy is more to strengthen the mechanisms of defense like sublimation or even denial. So a second problem that we are addressing in a different clinical trial is problems with retention. And we're doing this in a trial on pathological gambling. So pathological gambling, for those of you who may not be familiar with it, is essentially people who gamble too much. And of course they get into trouble, both financially, but also socially, professionally, and with all kinds of issues. And the cost of pathological gambling, as you can see there, for the nation is about $5 billion. So it's not a trivial issue. The prevalence of pathological gambling, depending on how you define it, if you use a very strict definition, is probably 1 or 2%. But I think if you use a broader definition, it's probably double, it's probably 4 or 5%. And let me go. So in this study, we're comparing two psychotherapies. We're comparing CBT, a type of CBT called relapse prevention that we know is quite effective. And what CBT does for these patients is it teaches them some of the cognitive biases that they have and why they expose themselves to the risk of gambling, and eventually they gamble. However, psychotherapy as medication, if you have an antibiotic but you don't take it, is not very effective. So psychotherapy, if you don't attend to the sessions and you don't learn the techniques, is not very effective. And so there's very high dropout rates in CBT for pathological gambling. So we were trying to find how to improve. So the efficacy of CBT is very high, but the effectiveness is very low. So we were trying to improve the effectiveness, and what we thought we could do is add motivational interview, which is another intervention that by its own name increases the motivation of individuals to engage in treatment and stay in treatment. And so we have devised a psychotherapy called cognitive motivational behavioral therapy that essentially what it tries to do is increase and maintain the motivation of individuals, and at the same time teach them the skills that they need to avoid the stimuli that are going to put them at risk of gambling, and also decrease the dropout. So in that study, what we're doing is we have two sites. Each site is going to randomize 100 patients, and in each site, 50 patients will be randomized to CBT and another 50 to this combined intervention of motivational interviewing plus CBT. And they are treated for about 12 weeks, 1 session per week, and then we're going to follow them up for 1 year to monitor relapse, the risk of relapse. And so the third problem is even more complicated, is the treatment of depression in Hispanics. And in this problem, we have two issues. One, as you know, Hispanics are the largest minority population in the U.S. and probably the largest growing. They have rates of depression that are probably comparable to the white population. But with Hispanics, we have two problems. One is with access. We have actually three problems. One is access. Hispanics have more difficulty accessing treatment than non-Hispanics. The second is that even when they access treatment, they receive lower quality of treatment. And the third is retention. So we have access, quality of care, and retention. So what we decided to do in this study is to essentially sort of try to simulate what the kind of treatment that a patient would receive in private practice. So besides doing research, I also see patients in private practice. And I thought, well, how would I treat a patient in private practice, and how could I design a clinical trial that would sort of simulate this practice? And so the control arm in this study is medication treatment using a well-established algorithm called the Texas Medication Algorithm. And what we do there is that patients in negotiation or in discussion with the psychiatrist can choose essentially any antidepressant that they want. So on the one hand, we're giving them an evidence-based treatment, but at the same time, we're trying to honor patient preference. And as in the private practice, you can switch, the patients in this control arm can switch treatment whenever they want. So if they come the first day and they get, let's say, Zoloft, and they have side effects, the next day or in 2 days, you can change, you negotiate with the patient, you discuss it, but you can change treatment. And they can change as many times. We also allow them, as we would allow them in private practice, if they feel that for a time they're not ready to take treatment or they want to take sort of a vacation from taking treatment, they can do that. And the reason to keep them in the trial is that if somebody, again, was in my private practice and said, well, I don't want to take treatment, I don't think that the medication is working for me, can we wait for a few weeks? I would not tell them, well, you have to go and see another psychiatrist, I'm not going to see you again. I keep them in treatment. So I think it's a more realistic portray of how treatment is done. So that's the control arm. The experimental arm, what it does is, on top of giving them this freedom, we offer them psychotherapy. And the reason for that is that when we've done qualitative studies, our group and others, Hispanics tend to prefer or say that they prefer psychotherapy. So again, if a patient comes to my private practice and they say they want, if they say they want something that I don't think is evidence-based, I wouldn't give it to them. But psychotherapy is well established. So if they prefer psychotherapy, I give them psychotherapy. If they prefer combined treatment, they can have combined treatment. If they only want medication, they can get medication. And the reasons for that could be not only sort of subjective preference. For many of the Hispanic patients, for instance, they don't have enough money to pay for child care, so even though they may prefer psychotherapy, they just don't have the time to add the psychotherapy. So then they may prefer, at least temporarily, to have a medication. We also allow them to have the psychotherapy over the phone. They have to come once a month, but they can have many of the sessions over the phone, again, to facilitate access to care. And so, again, the goal of this trial is, on the one hand, to provide evidence-based medicine, but at the same time try to honor patient preference and sort of do a trial that is sort of patient-centered. And the design of the study is randomized. They get randomized to either the control arm, which is this medication where they can switch among medications, or the experimental arm, which we call the choice arm, where they can switch between the psychotherapy medication and the combined treatment. And the acute phase is 12 weeks, but then we follow them for 1 year, and we don't have the results, but we want to examine retention. And of course, the hypothesis is that we are going to have higher retention in the choice arm, and that's going to mediate improvement. So I think, again, these are sort of 3 examples of how clinical trials, I think, can inform comparative effectiveness in psychiatry. I also want to emphasize what Dr. Wang said. I think that it's very important also to conduct large clinical trials, which, even though they are expensive, can provide information that I think some quasi-experimental designs may not be able to provide. Now, at the same time, I realize that we cannot afford to pay for all the clinical trials we would have to do, or we would like to do. So I think some of the criteria or some of the occasions in which clinical trials may be preferred could be when we don't have any standard treatment, when we don't know the mechanism of improvement in certain disorders. I think it's probably also useful to conduct clinical trials like STEP-BD or the KT when we are going to look for treatment-resistant or sequential treatments. The reason for that is because if we wanted to do a quasi-experimental design, we would need an instrument for each sort of randomization, and as we know, it's very difficult to find an instrument, so finding an instrument for each sort of pseudo-randomization would be a little more difficult. And I think they're also useful for populations where we have very dropout rates, and it may be very, very difficult to come up with good and credible imputation techniques. And also for populations like Hispanics who have very limited access to treatment, and therefore we couldn't really find in observational studies the appropriate data to really make appropriate inferences. I think clinical trials may be useful in disorders or in situations where we have high prevalence, like in breast cancer we have very high prevalence of depression, so it may be worth doing clinical trials. I think also in situations where we can expect large effect sizes, like situations like pathological gambling or substance abuse, where there's very high dropout rates, so we can improve retention, then effectiveness is going to improve. And also in populations like Hispanics that may be very difficult to reach. As I said, at the same time, I don't think that clinical trials are the panacea or the only method. Of course, in many occasions, we will need to use other designs like quasi-experimental designs. I think we also, as clinicians, as policy makers, have to realize that there's going to be also always a tension between providing evidence-based care and providing personalized care. I don't think we're going to have enough information to at the same time provide evidence-based care and personalize the treatment. And I think that's one of the difficulties that we have to face. How do we allocate resources? What are the most important priorities? And how do we live with the tension between needing for information, but at the same time have to make policies and treat patients without having all the information? So with that, I thank you for your attention, and I don't know if you want to have the questions now or later on.
Dr. Blanco. Our next speaker is Ama Boa, who was gracious enough to trade her time slot with Dr. Kane. She comes to us from the program for integrative medicine and health disparities at the Boston University School of Medicine, and her talk is titled The Back to Health Trials, Comparative Effectiveness Research of Yoga for Chronic Low Back Pain in Predominantly Minority Populations. And it'll just take 1 second to set up the slide.
Hi, good afternoon. Thank you. My name is Ama again, and I'm going to be discussing today comparative effectiveness research of yoga for chronic low back pain, but I'm going to focus specifically on our recruitment and retention strategies that we utilize in these trials to maintain a very large, diverse population. So a bit of background, chronic low back pain affects a large percentage of our population, 5 to 10%, and it amounts to about $50 billion in healthcare expenditures each year. Conventional treatments such as medication have been found to be helpful, but they're often not satisfactory, and there hasn't been a lot of research in terms of long-term chronic pain management. And due to disparities in access and treatment, there is a disproportionate impact on minorities and lower SES populations. So minorities receive less low back pain patient education. They receive fewer specialty referrals. They receive less intensive rehabilitation, fewer opiate prescriptions, as well as less back surgery. Yoga has been found to be a promising treatment for chronic low back pain, but little is known about its feasibility in lower SES populations. Most past studies have only focused on white populations with higher SES and higher educational backgrounds. So what is yoga? Yoga is an ancient Indian practice that combines asanas or postures along with pranayams, breathing exercises, as well as meditation. And it exists in this country. There are disparities in yoga use by race and ethnicity, by income, as well as by education. So why CER for yoga? Yoga is a very complex intervention, and it actually is well suited for comparative effectiveness research. This is due to the lack of a true yoga placebo. There aren't many things that you can put head-to-head with yoga and say that you're actually comparing apples to apples. Additionally, if we thought that if you compare yoga to more conventional reimbursed treatments, and utilizing patient-centered and cost outcomes at the same time, you'll be able to evaluate yoga's viability as a mainstream treatment for chronic low back pain. So for this study also, we wanted to see, is this generalizable to a multitude of diverse populations? So our research rationale was that minority and low-income populations are more likely to be negatively impacted by low back pain, and that's due to disparities in access and treatment. And they're also less likely to use yoga as a treatment for low back pain or just to use yoga in general. And so in order to rigorously and pragmatically study yoga for low back pain, trials really need to encompass all populations and really target all affected groups. So we decided in this study to look at evidence-based treatments for chronic low back pain, and this includes education. And here, I'll get into it later, but here it's in the form of a self-care back pain book, and then a physical therapy classification system, which is an evidence-based and treatment model, which is used primarily in Pittsburgh, but also nationally, and then also with yoga, which there has been previous research as to its efficacy for low back pain. So our research trajectory. The principal investigator on the study is Dr. Robert Saper, and in about 2007 he received a K Award from the National Center for Complementary and Alternative Medicine. This allowed him to implement a small pilot study for 30 individuals, and this was published in 2009. It was called Yoga for Low Back Pain, and it focused on 2 community health centers located in Boston, and they're located in racially diverse, low-income neighborhoods of Boston. And then from the results of that study, he was able to apply for a larger R1 grant. And that grant has 2 phases, the first phase of which we completed last fall in 2001. That was called Yoga for Low Back Pain 2, and it was actually a dosing study to really look at what is the appropriate dose of yoga for chronic low back pain. And again, it focused on predominantly low-income minority populations, and so we worked out of 5 community health centers, as well as Boston Medical Center. And Boston Medical Center, for those who don't know, is the largest safety net hospital in New England, and it has a large network of community health centers that are affiliated with it. And we are really lucky to have that in Massachusetts, and a lot of that is due to the fact that we do have Commonwealth care and near universal health insurance. And then later on this year, we've actually just recently started recruiting. We'll be taking part in the Back to Health study. And the Back to Health study is a random non-inferiority comparative effectiveness trial comparing yoga to physical therapy to education for chronic low back pain again. And we're working out of 5 community health centers again and Boston Medical Center. And the physical therapy intervention is actually implemented by a private organization, which is actually based out of one of the community health centers and works within the Health Network. And they're called New England Physical Therapy Plus. So a little bit of background on the yoga pilot. The Yoga for Low Back Pain, RCT, took place at these 2 community health centers, and there were weekly yoga classes for 12 weeks compared to a usual care waitlist control group. Mean pain scores for the yoga decreased from 6.7 at baseline to about 4.4 after 12 weeks, and that was found to be statistically significant. And additionally, after 12 weeks, those in the yoga group compared to usual care reported that they had less analgesic usage, less opiate use, and greater overall improvement. From this, again, Dr. Saper applied for an R1 grant, and actually at the bequest of NCAM, they specifically asked for the dosing study. So this past fall, we compared the effectiveness of 12 weeks of once per week yoga to 12 weeks of twice per week yoga, supplemented again by home practice in predominantly low-income participants. And our Hatha Yoga protocol that we utilized was tested in the pilot and then retested again this past fall. It is standardized. Hatha Yoga is really one of the most common forms of yoga, and however, our teachers that we use come from a variety of backgrounds and different schools of yoga, and that's just to help with generalizability. We also have both male and female teachers, and they all come from a diverse background. Our primary outcomes of interest are low back pain intensity, back-related function, which we measure using a modified Roland-Morris disability scale, and pain medication use in the previous week. We enrolled 95 participants, and they were randomized 1-to-1, and each received $100 honoraria, as well as all the yoga supplies and support materials that they might need to practice at home. We collected data 3 points during the course of the study, and some of our inclusion criteria were adults age 18 to 64. You had to have chronic non-specific back pain, meaning it wasn't linked with a clinical pathology like spondylolisthesis or spinal canal stenosis. And you also had to be willing to give multiple forms of contact information, as well as you had to speak English well enough to complete our instruments as well as take the yoga classes. So to get into some of our recruitment strategies and how we were able to recruit a diverse population for an intervention which may not be familiar to most, just in general, successful research requires efficient and effective recruitment and retention strategies, and previous research has shown that socio-demographic factors do influence people's participation in research studies. Minority patients are less likely to participate in clinical research, and they're more likely to experience barriers to participation and lack of awareness of these studies. And again, complementary and alternative medicine in general is disproportionately underutilized by minority groups. However, that does vary in different modalities beyond yoga. Part of our recruitment process started with branding our studies. So the first study was yoga for low back pain. The second was yoga for low back pain 2. We actually got a student graphic designer to create our logo for gratis, and this is used not only on all of our recruitment materials, but we also have quite a bit of swag, which are incentives that we utilize both during recruitment and during the course of the study to retain our participants. And these include things like Post-it notes, pens, reusable shopping bags, mugs, and other items such as that. I come from a very extensive hospitality background, and so I actually incorporate a lot of my hospitality training techniques into training our research staff. And I found that that actually works really well because there are actually a lot of similarities between healthcare and the hospitality industry. And so some of the things that I really train individuals up on are cold calling and being able to talk to people on the spot about everything. I like to call it highly personalized service and really never saying no to anybody, but always being willing to go and find an answer or just holding off before you make any sort of definitive decision. And then also what I like to call upselling, but here I really like to discuss it in the form of really having a complete knowledge of our intervention here, or our product, which is our intervention, and being able to discuss it in a variety of different ways to a lot of different people who may not have the same sort of background knowledge on it. And additionally, we look for research staff who are culturally sensitive, and that's kind of something that's very hard to measure, but we really try to train people up in terms of learning about the communities that we work in. We spend a lot of time in each of the different neighborhoods that we work out of. And we eat in the local restaurants, we talk to local businesses, and we really try and get a flavor for what each of these communities look like, what the values are in the communities, and really what's important to the individuals who live there. We recruited from Boston Medical Center again, and this map sort of shows the area that we're working with. Boston Medical Center is there in the center, and sort of down below it are all of the community health centers that we work out of. They represent neighborhoods that have individuals primarily of African Caribbean background, as well as Vietnamese, Portuguese, Cape Verdean, and that's the majority. So our recruitment strategy sought to minimize the barriers to minority participants enrolling in our study, and we address that through literacy level, awareness of the research, and really transportation. We use a tiered recruitment strategy, and all of these different methods individually, there has been research as to their efficacy and their use, but we really put them all together into one tiered recruitment strategy. We began with informational presentations at each of the community health centers with the staff and providers, really discussing what our inclusion and exclusion criteria were, giving them some background data and information about the efficacy of yoga for chronic low back pain, and also telling them how they can refer individuals into the study. We posted flyers in all of the community health centers. We had brochures that utilized culturally appropriate photos, and we also sent targeted letters from each of the community health centers. And for these targeted letters, we identified patients using ICD-9 codes for low back pain and those who had been seen in the last 2 years at the community health centers. And we utilized the center's logos on each of the letters as well. Each of the letters was signed by the staff and providers of their community health center where they received treatment. Additionally, and probably the most novel thing that we have in our study, is that we utilize a physician site champion. This individual is a provider at the community health center who had been identified during the grant writing stage and was actually written into the grant. They receive a small portion of salary support, and for that they really serve as a liaison between our research study and the community health center. They are a point of contact for any other providers who have questions, and they also help facilitate some of the logistic processes such as scheduling rooms and scheduling these staff and provider meetings. We collected data weekly on the number of inquiries we received, how people heard about the study, and ultimately how many people enrolled by each of the different methods. And from that, we iteratively modified our recruitment strategy to really focus on the ways that we're bringing the most number of enrolled participants. Here's some examples of our recruitment materials, the letters, the brochures, and just our general flyer that we use. In the span of 4 months, we received 631 inquiries for our study. This really speaks to the demand that's out there for other treatments for chronic low back pain. Many people had tried everything else, and so they were looking for really anything that they could try additionally. From that, we screened 86% of those individuals. We had a 30-minute telephone screening. We passed about 181 individuals, and ultimately we enrolled about 18% of the screened individuals, or 95. We found that though letters, flyers, and brochures had the most number of screened individuals, it was actually a physician recommendation that yielded the most number of enrolled participants. So it really speaks to needing physicians and providers on site, understanding what the study is, and filtering participants in your direction. Some of the demographics of our study, our mean age was approximately 48. We were 72% female. It had about 20%, it was about 20% white, about 62% black, 17% other, and that really encompasses a very broad range, and 9% Hispanic ethnicity. About 2/3 had incomes below $30,000 a year. We had about 2/3 were on some form of public health insurance. About 1/3 had less than a high school education, and about half were unemployed and not looking for work, or disabled and unable to work. Some of the retention issues that we addressed were really transportation, time conflicts, low literacy, lack of child care, and also staff inexperience at times. And things that we found to enhance protocol flexibility or enhance adherence included protocol flexibility, cultural sensitivity, having alternative contact info, frequent reminder calls, and utilizing local settings. Some of our retention strategies included we held 17 yoga classes a week across all of the community health centers that allowed for flexibility within the individuals. We had weekly reminder phone calls to participants prior to their classes. We called participants if they missed class within 24 hours to really troubleshoot with them. We provided assistance for child care and transportation. This either came in the form of vouchers and bus passes, and we also had staff on site who were willing to watch individuals' children so they were able to still come to class. We offered makeup classes. We had an attendance-based raffle for those who had high attendance. We also staggered the distribution of our honoraria, and it was handed out in class, and we utilized gift cards at the request of the community health centers. We also gave everyone yoga home practice supplies. Our attendance rates at the end of the study, or the end of the 12 weeks, we found that our mean attendance rate for the once-a-week group was 73%, and the twice-a-week group was 62%, and some bivariate analysis found that attendance rates were not associated with race, gender, satisfaction, or treatment preference at baseline. Just a bit about our results. So we did find a clinically significant and statistically significant reduction in overall pain. It was greater than 2 points on a 11-point numerical scale. And as you can see, the once and twice-a-week groups were very comparable in terms of their results. Similarly, with the Roland-Morris, which is a 23-point scale, we had approximately a 5-point change, which is both clinically and statistically significant here. However, the difference, again, was not significant between the once or twice-a-week group. And in terms of pain medication, we did have a significant, statistically significant reduction in pain medication usage as well as NSAID usage, but again, between the two groups, it was not significant. This really shows that the once and twice a week, though between the two of them, there did not seem to be difference in terms of the effectiveness of once-a-week yoga versus twice-a-week yoga. Some challenges to keep in mind: recruitment and retention activities are very time-intensive. We work both from 8 a.m. to 8 p.m. as well as on Saturdays. And it requires a very large staff, which is often not written into your grant, so you have to be quite creative. I have a staff of about 15 to 20 students, a variety of students from undergraduates through doctoral students as well as academic fellows who work on the study for a variety of different purposes and different amounts of time, some for credit, some not for credit. And also, it's important to write funding into your grants for both recruitment and retention activities. That includes the swag and incentives you might purchase, as well as thinking about transportation and childcare and how you're going to actually get people to the centers. Some unexpected events that occurred during the course of our study that did affect our retention included violence and death of family members of participants, being mindful of just where you're working and that people do have real lives still going on. I live in Boston. The weather is very much an issue. When it rains, snows, or anything, people do not come out, and also the safety of our staff. And lastly, I just wanted to touch on the Back to Health study, which recently started recruiting, and again, our outcomes are pain and functional improvement, and we will also be looking at cost-effectiveness research, cost-effectiveness from the perspective of individuals, insurers, and society. And I'm out of time, so I won't run through our model, but thank you very much.
So thank you to all the speakers. It's really been a wonderful day, and we're only about halfway through, so tomorrow we have 14 more speakers to go through, so I look forward to that as well. It also gives me great pleasure to introduce the Director of AHRQ, Dr. Carolyn Clancy. Dr. Clancy's been the Director of AHRQ for almost a decade now, and when I looked at how that coincided with our comparative effectiveness, I think the year you became Director was when we got the authorization for comparative effectiveness, and 2 years later is when we got the first appropriation. So CER has been really integral in your leadership here, and many of the programs that you're seeing the productivity of those programs started with Dr. Clancy and, of course, Jean Slutsky, who is the leader of the Effective Healthcare Program. So given it's relatively late in the day, I asked Helen to give just brief comments, but I think she'll also be aware if you want to stay after and ping her for a few minutes, she'll be here for a couple minutes. But Dr. Clancy?
Well, good afternoon, everyone, and I'm sorry I had to walk in the middle of that because it sounds quite fascinating. So I have to ask you a question. Are you looking at self-efficacy at all for people participating?
No, not individually, but we're really looking at the overall effect.
Yeah.
But not the self.
It's pretty interesting. It also reminded me that one of the coolest studies I thought of comparative effectiveness that wasn't funded by AHRQ. I put them in two different categories because ours and your work are always the coolest and the top of the pile, was that study of Tai Chi, which was just like, wow, how great is this? And, you know, there was this incredibly thoughtful, learned editorial, not quite arcane, but, you know, sophisticated, and about do we know enough to try something? And I thought, oh, my God, look at the people you're trying to help here. Of course, I mean, and it doesn't hurt anyone, I mean, which I thought was even better. So, you know, in addition to the fact that we got this very explicit authority, and I really can't say enough about Jean's leadership of this work from the beginning, and she has always, always really focused on methods. So when it gets tedious, remember how important it is. I would just also remind you that this is sort of our second generation, if you will, of outcomes research, broadly defined, which we keep reinventing and giving it new names, which is great. But some of the most important lasting contributions really came about as a result of bringing people together from multiple disciplines who don't speak the same language, sometimes actually don't like being in the same room with each other. And I don't mean people who happen to have degrees in both. That's always very nice to have a few of those around. Presumably they're bilingual, although I've noticed they just kind of switch sides in discussions and arguments. But in fact, out of that sort of tension grew some very, very important methodological contributions that continue to this day. And today, your work couldn't be more important, partly because, you know, X number of years later, there's more options to think about. And so the notion of being able to predict with some accuracy who's likely to respond to which treatment, I sometimes think we will never actually have back pain solved, but that's a much longer discussion. to be able to have some sense, to be able to predict response based on an individual's characteristics, everything from their genetic makeup that's coming online to their social and other characteristics and other diseases, is incredibly important. And you all are the engine of something really, really big. So I think for as much as I want to say kudos right now, and I will say that, I think that we'll look back on this and recognize it for the seminal contributions that it has been. My guess is that you saw a lot of your hard work reflected in the PCORI Methodology Committee report. I can't actually say because it's still sitting on my desk, and one of these days I'm going to get to it. But since they slowed down the public comment period, I have a little bit of a breather. But the methods matter a huge, huge amount. Tutored by all of you and my colleagues here, I tried to explain this to a couple of people on the Hill once and actually got them terribly worried when I told them that we didn't actually have a rock-solid single approach to assess harm. And they said, what do you mean? You know, I thought FDA had this all figured out. And I said, oh, not actually. It's, you know, very much a very vital dynamic area. If there's one area where I would love to get some ideas from you, which isn't today because you're here to hear about, or tomorrow, about some of the exciting work in progress, it's how do we get more creative in the future about how we fund research, rather than sort of probably too often defaulting to this, well, a clinical trial would be the best, but we can't do a clinical trial, so therefore we can do observational studies. How do we actually think creatively about when we ought to literally be asking teams to have both? There's some very nice examples of that out there. I don't know that we've exploited that as much as we could to build in the issue of heterogeneity and being able to assess that as part of one grand study design. That said, I'm mentioning these big ideas at a time when we all know that funding is going to be a little bit precarious. So, and I recognize that that's very high on your brains as well. But I think what you're doing is incredibly important. And at the end of the day, methods really, really last, right? Studies will be replicated, and some of them will be consistent with the original findings, and some of them will raise more new questions. That's what research is all about, what makes it exciting. But the methods of taking on a question, particularly at a time when we're getting to a place where we're almost going to be drowning in data. You know, the history of this field has always been, I get my database and it's my database, and no one else can touch my database because it took me so long to get this Medicaid data together or whatever it was. Well, you know, pretty soon, between Health IT and a variety of other policy initiatives to encourage this, getting data aren't going to be the problem. Making sense out of the data is going to be the really, really big challenge, and probably also counteracting false claims about what appears to be a deceptively simple interpretation of one big old huge pile of data that just happens to be completely wrong, will also be a big challenge. So we remain very, very excited about your work, and frankly, this generation of DECIDE has shown us what collaborations can mean across teams, across disciplines, across institutions working on common topics. Doesn't come naturally to how academic centers are set up and so forth. So you're really blazing some very, very important trails. So I'm going to stop here, having said you rock. I'd be happy to take any questions about what things look like in the future, recognizing that uncertainty is kind of the new normal. Or we could just leave it on a high note, which would be perfectly appropriate as well. If there's one area where I think we're also going to need additional methodological development, so I think it's very, very important that it was on your agenda for today, and I look forward to learning more from your work. It's in the area of delivery system interventions. Now, the good news is, when I used that phrase once to a colleague here about 15 years ago, I could tell for her it was like nails on a chalkboard, right? Interventions was something she associated with, IV medicine or something clinical, that you would apply that to new ways of trying to figure out how to get to higher quality, lower cost care, just didn't work for her. Now we say that. So maybe we're coming to the idea that we can bring science to bear in this area, even though we know that the urgency confronting the cost situation means that people are just going to be trying stuff. So earlier today I was at a summit on bundled payments. Wow. There's one great demonstration, and that's it for evidence on bundled payment. But boy, people are energized all over the place. And I can make a rational case for it as an approach, but we don't have the same kinds of taxonomy or definitions of what an intervention is. We all know what 20 milligrams of Lipitor is. It has a meaning that we would all interpret in a fairly consistent fashion. For delivery system strategies, approaches, and so forth, oh boy, you've seen one, you've seen exactly one, and somebody else is doing it a little bit differently, and how that interacts with context and so forth isn't really fundamentally all that different than how a clinical intervention interacts with the unique characteristics of an individual. But trying to figure out how we can take some of your work and apply it in that space, I think, is going to be very, very important, and definitely an area where we plan to be developing more work. So with that as a hopefully encouraging note, thank you for allowing me a few minutes to just come say how proud we are to be supporting your work.